So, what a great time to talk about this, because I was just talking to Dr. Sullivan about how we met, and it was through the initial trials with anti-PD-L1 drugs, which sort of fell by the wayside, except if you were going to do adjuvant post-chemo rads in lung or Merkel cell. Can you tell I just reboarded? Anyway, so what's the optimal ICI? Is it PD-1 versus PD-L1? And could it be both, by the way? It could be both. Here's the rationale for immunotherapy. But I would say that aside from this, what I learned about squamous cell carcinomas is those that occur in patients who are immune suppressed, either post-transplant or for connective tissue, X, Y, and Z, they have 100 to 1,000 times more of a mutational burden. So immunosuppression may be where we talk about this. So what do we do? This is just about transplant patients. What's the safety here? They're associated with high acute rejection rates, but result in reasonable tumor response. And there's trials that show, and we'll talk about one for cutaneous squamous and others. Where does anti-PD-1 and PD-L1 work? Well, you got to go back to when we all started to learn, didn't know the outcomes, but we're trying to explain to our colleagues where they interact. And I should have put the big rebus picture here, but PD-1 antibody, PD-1 interacts with PD-L1 and PD-L2. PD-1 antibody blocks PD-L1, but if you have excess PD-L1, it doesn't block PD-L1 interaction with CD80. Put a pin in that, okay? PD-L1 antibody blocks PD-L1, does not block PD-L2. That's very important, as we'll talk about, but as we've known that PD-L2 is upregulated with interferon rises on viscera to provide a protective effect. And that's why we sort of have PD-L1s and 2s, is to protect us from inflammation, or else I would have Crohn's disease, you would have some dermatitis, you'd have lupus, etc. But it also blocks PD-L1 interaction with CD80, a negative regulatory effect. And so there is some data that if you block with a PD-1 antibody, PD-L1, and there's inflammation, CD80 can go up and you can have immune suppression that way. So all of this is that all of these interactions may contribute to immunosuppression in a tumor and tumor-draining lymph nodes. And this PD-L1 CD80 may be important in the context of anti-PD-1 treatment. And there are trials that looked at combination. Actually, we did a great one with MedImmune that owned both similar drugs. Bristol had both drugs. They got rid of one. BeiGene did one in ovarian cancer that was published in CCR that looked pretty good in a cancer that, if you go back to that graph, next to uveal melanoma sits and glioblastoma. So when these drugs come and we have tools, this is very interesting how we can utilize them. So the dual role here, and I don't have the notes and I would just read from the notes, is that in the tumor microenvironment, it's important for immune suppression. But outside, in normal tissue, it's important for tissue protection. So we had always said this, that they may be safer to utilize in patients. Unfortunately, some of the early PD-L1s took time to develop and lost the race to being approved or had lower response rates, and we never looked at long-term outcomes. So here's a way to think about it. It's a huge balance here. Th1, interferon gamma, it's held in check by PD-L1. It's important for cellular immunity, T-cell regulated autoimmunity, graft rejection, anti-tumor cytotoxicity. But on the other side, we have this, what's been held in check by PD-L2, humoral immunity, allergy, antibody-mediated autoimmunity, and tolerance. So this is important. PD-L2 negatively regulates T-cell activation. It's important for tolerance and may be a co-stimulatory molecule. So if you block it, you may be helping immune therapy, but there may be other things happening. So PD-L2, I looked this up a long time ago, but it's so important here to understand where it goes. PD-L2 interacts in a direct manner. PD-L1 involves complex conformational changes, so it may bind first before PD-L1. And what does that really mean? We haven't really looked at it. Let's go into T-cell exhaustion, and that's the PD-L1 CD80 interaction that we talked about in the interest of time. I love ChatGPT. ChatGPT brought this up in like 2 minutes. But when we talk about where we benefit, we always are worried about toxicity and where we take a drug like this. And if you look at avelumab and durvalumab in immune-related adverse events grade 3 to 5, they're much lower than we have seen with other drugs, even cemiplimab. In the costibelimab data, which I've become very interested in and have been exposed to recently, I will say that the trial that they used to lead to its approval was somewhere between like 120 and 140 patients, locally advanced and metastatic. So it is similar to the cemiplimab data in this cohort of patients. The trials, although they cannot be evaluated head-to-head, the numbers are similar, okay? And what was interesting here is the serious AEs, although they were high, the immune-related adverse events of, they only saw 3 toxicities, and the majority, 2 of them were dermatological. So not really life-threatening in relation to, and you can see that here. Sorry. No grade 4 and no grade 5. Well, that's interesting. So where do we go from that? Well, maybe this is better. This is the cemiplimab for kidney organ transplant recipients. This is Glenn Hanna at Dana-Farber with advanced cutaneous squamous cell carcinoma. Here's the rationale here. If you look at it, I'm sorry, that's so small, but they start with immune suppression as part of it. Prednisone, as you go forward. And the results showed response, but the results, they were very interesting that when you gave it with an mTOR inhibitor and pulse prednisone, no kidney rejection, encouraging durable anti-tumor activity, although when you talk to people who have used this, there is rejection. And this is just kidney. What about someone with a heart transplant? What about someone with something else there? And also the cetuximab data, while you think that it's just the blockage, cetuximab is involved in a lot of immune regulatory activity. So you would expect toxicity to go up, and the need for a partner would be there. So this is cetuximab plus avelumab versus avelumab alone. We've just talked about this. The Alliance study, which showed improved progression-free survival. Here's an overall response rate with anti-EGFR in pretreated, naive, other areas. Well, this is real data, real benefit that toxicity needs to be decreased in. Just as an aside, combinations also important as you go forward. This is a patient that myself, Dr. Ferries, our dermatologists, and others treated. And this is a patient who showed up was in our clinic on July 2018, had all of these horns show up. Had surgery, radiation, and chemo. Nothing worked. We started him on TVEC. A couple months later, he had this submandibular node that showed up. We then switched to injecting the submandibular node, and it's too far away, but that's 2 years later. And he remained in a remission, just like when we do these in-transits that appear on PD-1, et cetera. So there is a clear role here in tolerability. We're not the only people that have published this. There's a whole host of information there. And also, as we talked about, bispecifics. This comes from a talk I gave a long time ago that there are multiple different types of bispecifics, bifunctionals, et cetera. Why is this important? Because there is a whole host of new drugs coming that are bifunctional, bispecific antibodies that target PD-1 and PD-L1. The Bristol drug is a PD-L1 with a VEGF, so an option for your patients. Antibody-drug conjugates could be something that you look at. And the next slide, hello, shows that there are multiple trials, but way down there are cutaneous squamous cell carcinoma trials. So you're never without an option for your patients. And with that, I say thank you.